All right, thank you very much, Ron, and it's a pleasure to address what's become one of the great meetings in our field, and so we appreciate the opportunity. So thank you for that. We're going to talk about large bore closure and TAVR programs today, specifically focusing on the MANTA device. I have the real pleasure to be joined today by real experts in the field, Nicolas van Mieghem from Rotterdam, Pedro Villablanca from Henry Ford. Dr. van Mieghem has been really the leader in the field in terms of studying this device in a kind of a prospective, systematized way. And Dr. Villablanca and I will share our experience at large volume U.S. centers incorporating MANTA into our practices. So we appreciate the opportunity to talk to everybody and look forward to sharing our perspectives on that. Dr. Van Mieghem, if you want to get us started, that would be outstanding.
So what I'm going to do in the next 10 or 12 minutes is to discuss the real-world experience and some evidence from prospective studies, and both studies from the United States and in Europe. These are my conflicts. So let's start as a background. There is not that much data on large bore arteriotomy closure, and I think the most compelling before the MANTA experience was in 2015, where you had these two trials, one data from Catania on the left-hand side, on the right-hand side, the multi-center control study. And what is clear in both studies, they were comparing suture-based closure with ProGlides or with ProStar, is that in Catania, they were better with ProStar, and in the multi-center experience, they were better with ProGlides. But in both studies, you had any vascular complication in 20% or more. Then if you look at more in-depth analysis, then stenting was required in up to 5%, so covered stenting in up to 5% of the patients in the control study, and urgent vascular surgery in almost 3%. So then in comes the MANTA plug-based closure. This is the first dedicated large bore closure device that entered the commercial market. And on the left-hand side, you see the early CE mark study. And on the right-hand side, the IDE trial in the United States. 50 patients in Europe, 263 patients in the United States. And the interesting part in the European data set was that all the operators were basically new with the technology. So we had their early experience captured. And in those 50 early patients, there was one major vascular complication and super fast time to hemostasis. In the IDE trial, more patients were enrolled, more centers were involved, and patient selection was somewhat different. Their major vascular complication rate was 4.2%. So then we try to confirm these excellent results in a post-market registry. 500 patients in Europe and Canada. Operators had somewhat experience with the device, so I had to have at least 10 MANTA cases under their belt. And the primary endpoint was a major vascular complication occurred in 4%, a secondary minor complication in 5.8%. So in general, still any vascular complication below 10% as compared to 20% in the multi-center control study with suture-based closure. I think of notable was that bailout was required with covered stents in 1.4% of the patients and vascular surgery in 2% of the patients. This is another illustration of the vascular complications, but then in the total number of patients. So you can see that the number of complications was quite low in this 500 patient registry. So the majors 4%, minor 5.8, and again, surgery in 2.4, covered stents in 1.4%. I think if you compare the three prospective registries, then it's clear that they all had independent clinical event adjudication, but their inclusion-exclusion criteria were quite different. And they were more stringent in the IDE and the CE mark study. They were more liberal in the MARVEL study. And this is already attesting to the relative ease of use and the good outcome with this device in a more general patient population, because we managed with MARVEL to basically copy the results of the IDE trial in the United States. So we did a patient-level meta-analysis. We pooled all the data from these prospective registries, and we ended up having 891 patients, their time to hemostasis was half a minute. So super fast, especially if you compare that to suture-based closure. Major complication rate, 4%, minor 4%. So basically any access complication in less than 10%. And also importantly, all the complications except for one were diagnosed within 24 hours. So basically suggesting that this technology also is attractive in a lean TAVI with an early discharge protocol. Bailout surgery or covered stenting was required in less than 4% of the patients, and also of interest that operator experience was not associated with access complications. So basically the learning curve seemed to be very steep. One of the interesting findings of this patient-level meta-analysis was a phenotype that was associated with vascular complications and especially occlusions and stenosis. And this was a combination of a small femoral artery diameter, but also a deep arteriotomy. Basically, in obese patients with small vessels, those were the patients that encountered complications. And this is also, and another interesting feature was the use of a left femoral approach and females. So females, that is not a surprise. We know that women have more vascular access site complications than men with large bore access. But the left femoral approach was a little bit of a surprise. But if you then think back about it, then you can understand that, okay, why would you go through a left femoral approach? Probably because there is already advanced peripheral arterial disease in the patient. These were by union multivariate analysis, we had the female gender, the left femoral approach, and then this phenotype with a small vessel in. Those were the predictors for access site complications. Then we followed this up, these prospective registries, with a randomized study. And this is the MESH TAVI trial, which is a 210 patient trial in Toulouse and Rotterdam. No funding for this trial, comparing MANTA with 2 proglides. These were the inclusion criteria. We tried to be as liberal as possible. And this is also illustrated in this slide, where you can see that from the 350 patients that were treated with TAVI in Rotterdam, 150 were entered in the study. The other patients were entered in other randomized studies predominantly, or refused to participate in the study. So not very, so this was quite an unselected set of patients, and also challenging anatomies, because you can see that almost 40% of the patients had at least moderate or severe calcium in their femoral arteries. 1/3 of the patients underwent TAVI with a sapien valve, 50% had a supraannular evolute system implanted. And these are the data comparing MANTA with 2 proglides. Basically, no significant difference in major or minor access site complications, although numerically we had some events with MANTA and somewhat more versus proglide. But again, this can be a play of chance because of the low number of complications. Oops, let's go back to that one. And what was striking was that there were more vascular closure device failures with 2 proglides versus MANTA. And the definition of vascular closure device failure was the presence of a vascular complication or the need for more than 5 minutes of manual compression to control the bleeding, or the need for additional closure devices. And this is illustrated in this cartoon in the middle, where you see that there was a 20% failure rate with MANTA that was predominantly solved with manual compression or with a covered stent or a vascular surgical intervention, but 40% of the 2 proglides failed and required an additional closure device. So basically, you're not then, if you look at it from a commercial point of view or from a economic point of view, you will have to compare a MANTA with 3 proglides or with 2 proglides and an angioseal to be able to compare it from an economic point of view. The failure rates were, the failure pathophysiology or pathophysiological mechanisms were different from with the 2 devices. Of course, with proglides, the sutures can tear, you can have incomplete approximation, and basically, because you have that safety wire, you can use an additional closure device. So we did not use covered stents or vascular surgery in the ProGlide arm. With MANTA, the failure rate is incomplete apposition of the toggle and or the plug, occlusion of the artery by toggle or collagen, the collagen that not reaches the vessel but gets lost in the subcutaneous tract, and bailout vascular surgery was required in 2 patients to deal with a major vascular complication, and covered stenting had to be used for 4 minor vascular complications. I think there are some limitations to MASH. The overall sample size was not enough for meaningful subgroup analyses, and overall only 14 vascular complications occurred in the entire trial. And also, I think this is important, we did not use protamine systematically when using MANTA. And this is definitely something that we changed in our practice. And I think there is also an unbalanced overall experience with the 2 techniques. We were more experienced with ProGlides than with MANTA, basically, because we all by default were using ProGlides for 5 years or more before we started using MANTA for large bore closure. But I think what also is important, that the sample size was so insufficient to have an in-depth analysis. But what was striking was that the vascular complication rate was only 4% with 2 sutures. And this compares to 20% in the control arm and in the control study, and 15% in the Bravo 3 trial. So in conclusion, I think that it's fair to say that MANTA is the first commercially available biomechanical vascular closure device designed specifically for large bore femoral arterial access site closure, and available both in the United States and in Europe. It is the best studied closure device for large bore arteriotomies. There are no randomized trials or other prospective studies with any other closure device available. Complication rates were low for both plug and suture-based closure, and the bailout options were fundamentally different for sutures or plugs. With that, I give the word back to you, Paul.
Well, that was spectacular. Thank you very much for running through all of the data for us. You've been really a leader in the field. Have you continued to study MANTA in your practice, and have you seen better rates with the use of protamine? We do use protamine pretty routinely in our practice.
Yeah. Yeah, so the moment we got the data from the MASH trial, we really, and also the data from this patient level meta-analysis, we really changed our practice. So I think we use MANTA in 60% of our cases and 40% sutures, and our MANTA complication rate has dropped to 1%. Any vascular complication, and in the majority, and I think the major vascular complication not occurred within the last 6 months. We also no longer required covered stents or vascular surgeons. So I think there are some important takeaways from these studies.
Do you have anatomic criteria, or is it operator specific which closure device that you use?
No, it's not operator specific. It is really patient specific. And I think we try to avoid the morbid obese patients for a MANTA. And also there are some situations, for instance, when a patient is not preloaded with DAPT, and we are doing stenting, especially if it's complex stenting, then we are a little bit hesitant to use protamine at the end of the procedure, because then, we assume that the antiplatelet activity is not in full force yet at that point. So we are a little bit afraid for acute stent thrombosis. So then we would not use protamine, and then we would prefer ProGlides.
Looking at data and looking at this systematically, we're going to talk now about 2 large practices in the U.S. that have incorporated MANTA in our experiences. I believe I'm going first, and then Dr. Villablanca will follow me. So let me share my screen. And can you guys see that now?
Yep.
Awesome. So I wanted to talk about, let me minimize this, minimizing complications with vascular access in TAVR. I'm the director of the structural heart programs at Sentara Heart Hospital. We did 500 TAVR last year, probably close to tracking to 600 this year. And we're very interested in looking at optimization, best practices, and procedural efficiencies. Here are my disclosures. So percutaneous large bore access with TAVR has greatly advanced the field of endovascular valvular interventions. And while trends are favorable, vascular complications are relatively common and remain a major source of morbidity and mortality in TAVR. And I want to look at contemporary practices, trends, and available devices and future needs. So what is an ideal large bore access closure device for TAVR? We want clinical efficiency, we want speed, reproducibility, cost obviously matters, and can we use it for unplanned or delayed closure in both TAVR and another large bore access? And it's just as a thought-provoking item to see what's out there. Trends in vascular access complications in TAVR. When we've looked at the STS database, as you might expect, as the devices have gotten smaller and techniques have improved, we've seen a steady decline in vascular access complications, but there is a persistent complication rate in the high 5 to 10% range, and that matters. What predicts vascular complications? Sorry, my slide. Female sex, larger sheath size, presence of peripheral arterial disease makes sense. More obese patients tend to have higher rates, and then obviously cut downs actually have higher complications from percutaneous access, although this is less of an issue as most centers are now percutaneous approaches. Why have rates declined? Well, technique does matter. Smaller sheath sizes in general has been a major factor. We now do preoperative planning, and then the wide adoption of best practices. Routine ultrasound, front wall access, completion angiograms are now a routine part of all of our practices, and this has helped us limit the amount of vascular complications. However, when they occur, and they do occur, the morbidity and mortality with bleeding vascular complications in TAVR are significant. At 30 days, all-cause mortality with a vascular complication is the odds ratios are 2.2 compared to no complication, and bleeding events are 3.7. So these are major episodes of morbidity and mortality in this high-risk population. Technique matters. When we look at U.S. sites, individual sites, there's a threefold difference in vascular complications between the best and what I'll call the least best sites. So technique does matter, and we need to constantly look at this to see if there are ways we can improve. So the current closure options, as you guys are well aware of, suture-mediated devices, the ProStar and ProGlide, for which we have extensive experience, has been adopted from other sites developed first for 6 and 8 French vascular closure. We've been able to adopt this to large bore access, and that's been successful, but this isn't purpose-built. The first in a new wave of purpose-built devices, the MANTA device, we've been talking about that. It's a collagen plug device that comes in 2 sizes. And we can talk about the advantage and disadvantage of suture of the 2 approaches. Suture mediated, the advantage, it's widely available. We have extensive data because essentially all large bore access until recently was based on ProGlide. It's a relative low cost. You can maintain wire position in case of catastrophe. We have bailout strategies. Reaccess is feasible. There's a range of French sizes and can be used in tandem or a hybrid approach with adjunct as needed. The disadvantage are it's pre-close only. You have to be thinking about it ahead of time. There is a pinching of vessel that occurs. It can't be used in calcified vessels. Importantly, it's not purpose-built. This was not defined for this patient population. We're adapting it. And there remains a persistent but real failure and complication rate with the device. With collagen plugs such as MANTA, the advantages are perceived advantages at least are speed, efficiency. More importantly, as we move forward with newer operators, reproducibility. The range of French sizes is impressive. It's actually 10 to 25 French outer diameter. And we do have some delayed closure options. If you did not do this ahead of time, you can use this after the fact. Disadvantages, cost in the US at least remains a major consideration. Loss of wire position, less bailout options once the footplate is deployed. Severe calcification, although I'll say that's a relative contraindication, less robust data. And one of the things that we're trying to do is develop more data. Limited reaccess, although again, not a huge issue. And the finite failure and complication rates persist. So what is the device? Not everybody here is familiar with this device. I'll just go through it. It's the first commercially available biomechanical vascular closure device designed specifically for large bore access. If you've used an ANZISeal, you have some insight into what this device is. There's 2 sizes. There's a 14 and an 18 French. The 14 closes 10 to 14 French holes, and the 18 goes up to 25. It can be used for TAVR, EVAR, VAD, Impella, anything that requires large bore arterial access. And we've used them in all of those settings. Indications, it's indication for closure of a femoral arterial access site while reducing time to hemostasis following use of large bore access or sheaths up to 25 French. in endovascular procedures, and they are no known contraindications to the use of the device. The components are a sheath, a delivery tube for the collagen plug, and then a depth locator or a measuring tool, which is used preliminarily to guide the deployment site of the foot plate, although we have some workarounds for this if this wasn't used. The mechanism of action is a collagen plug. Very similar to angioseal, there's a foot plate in the artery, there's a collagen plug delivered externally, there's a nitinol marker which can be seen fluoroscopically, so you can know where your access site was in the relationship to the artery. And what are the advantages, the potential advantages? It's fairly straightforward to use with a single device. Time to hemostasis appears to be excellent, and it's a reliable closure. So we looked at this, and I'll show you. This was a video I took about a year ago with the iPhone, and let me turn the sound down there. Access is gained, and we go over a regular J-wire. We measure the depth, and so the operator here is going in and out with the measuring tool and trying to see where the arteriotomy is. Once you've determined the distance to the arteriotomy, when you get ready to close the device, we have a markers on the device. When we close it, we'll add 1 to that. The procedure is over. You can see in this case, it looks like we did a sapien valve. The E-sheath is taken out over the delivery wire. The MANTA device, first the sheath is brought in. You can see the operator, me in this case, is holding pressure with the left hand. The device is brought in. It's a larger one. The blue is the larger of the two devices. The dilator is withdrawn over the wire. The collagen plug will then be advanced over the wire. And again, most of you have experience with angioseal. It feels like a giant angioseal, but there are some small differences. The collagen plug is brought up over the wire. We've already measured the depth. That was the first video. This is brought in. These the two parts are clicked together. Okay, we've drawn back to the prescribed depth at a 45-degree angle. The foot plate is deployed. There's a rotating foot plate. You see that right there. It's pulled back and deployed. We pull back. There's a window that gives you some idea of how far back you are. Once you're at the proper length, the collagen plug is advanced down, and then the system is locked in place with some gentle traction. Okay. The wire is removed, and you have immediate hemostasis. And that is a very typical MANTA case that we do. We take the wire out, and we immediately perform a completion angiogram. Okay. So we looked at this. I liked it. We had a fair amount of new operators, both in the cath lab doing Impella cases and in our TAVR program, and they didn't have the 10 years of experience with perclose. And so we were looking to see, is there a better route? So we switched over to the MANTA. And basically, we moved our whole program to this. We went from our suture-based to the MANTA with multiple operators. The perceived advantage, we saw procedural efficiencies in a large volume program. We were hoping for at least comparable clinical outcomes. We wanted reproducibility across multiple operators, including 6 or 7 surgeons that joined us. And we wanted to have access for delayed or unplanned closures. Impella ECMO. As a large bore operator, I was getting a little bit tired of putting in the sutures for other operators to Impella and then taking it out. I wanted to be able to share this procedural efficiencies with my colleagues without having to be individually involved. Our data was good. We switched from suture-mediated closure to the MANTA device in October 2019. We recently looked at it, compared our outcomes for the first 595 MANTA that we used over the last year or so versus the previous 641 perclose. We looked at our TVT registry data. For transfemoral TAVR, our bleeding at access site was no different. Hematoma was no different. Our minor vascular complication with the MANTA device was 1.66, with the perclose 1.72, and major vascular complication with MANTA was 0.55 versus perclose at 0.78. So we felt it was at least comparable to the previous use of the perclose device, and very easy to teach across both cardiologists and surgeons. The typical complication with MANTA, and I think it's worth looking at, is usually an issue with the foot plate, that the foot plate doesn't fully deploy. So I'll show you a typical case here. You see our angiogram, which are DSA angiogram. You can see our access site down here. This is hemodynamics. And at the access site, we have loss of 1. I think the puncture site was right at the crotch of the femoral, and we've occluded 1 branch. We go up and over from the other side. I don't know if you can make that out, but what we're showing here is we're just taking a up and over catheter and a glide wire. We easily wire the vessel. Okay. And we, once we've established wire position, we simply take a balloon. We know what size the vessel is from our CT planning. We take a balloon and perform a balloon dilatation that usually opposes the foot plate against the wall. And we take a follow-up picture. And you can see here with the follow-up picture, we've established patency. 9 out of 10 MANTA complications can be addressed in the room with this technique, usually within a few minutes. And then we check a Doppler of the lower extremity the next day, and the patient can be discharged home. So as Dr. Van Mieghem was saying, we've eliminated most of the covered stents or cut downs that we need, and a simple up and over balloon technique, which is used about 1% of the time in our experience. So in summary, large bore vascular access complications during TAVR, while they are less frequent, remain a large source of morbidity and mortality and a potential target of opportunity. Both suture-mediated and collagen plug-mediated closure devices are effective, but frequently require adjunct maneuvers. Continued improvement in the technique and equipment will reduce cost, morbidity, and mortality in the TAVR population. And the MANTA device can be incorporated pretty efficiently into a busy contemporary clinically practice safely and efficiently across multiple operators from multiple disciplines. So I'm going to conclude with that and stop sharing here.
All right. So again, I'm going to talk a little bit about adopting MANTA and how you teach it and lessons from our initial experience that are going to be presented at ACC. I only just put some of the data. I can't publish everything. It's a combined data too with mechanical support and TAVR. Well, focus just on TAVR. So I think, and this is key, and we all talk about, I think TAVR success is 95% planning in the heart meeting as an outpatient. We all know what to do with the valve, where to land it, what to use, and which access are we going to use. But however, when we do a TAVR, I do think 80% of the procedure is the peripheral aspect of getting access, closing. You can do the TAVR portion really in 5 minutes after you cross the valve. And if it's a straightforward TAVR, it goes pretty easy. And then you have to you do a great case, you have to deal with the closure. And that patient that you're planning to send home hopefully goes home next day without any complication. So I'm highlighting that the peripheral skills and the closure is key aspect of of having good outcomes in a TAVR program. And I do think if you know how to use these big bore plugs, it's going to make a difference. Next. So what's the essential for access? You need to know CT as a radiologist. I usually, though you get a report, I look at them myself. I go through all the cuts, the 3D reconstruction to look for tortuosity, the calcium, the burden of the calcium, and the height of the bifurcation, et cetera, et cetera. And also I always use ultrasound and fluoro, and if I have doubts, I use vascular ultrasound just to define diameter sometimes. And then have all the tools necessary to bail out in the room. There are several techniques I do think the structuralists and the interventionalists should be familiarized, where you're dealing with any big bore access, including balloon tamponade, covering stents, snaring to deliver sheath or wires, and balloon tracking technique, shockwave. Because if you're not prepared to deal with a big bore sheath, you're going to see the consequences. And a case that should be straightforward, it can become a nightmare. And once you have all the equipment and the necessary techniques to deal with the closure and the access, then you need to think about the closure. What I'm going to use: suture devices, collagen plug, manual, like the old manual compression, or balloon tamponade, or it could be a combination of all of them. So what are the expectations, right? Hopefully we want this patient that has a very superficial artery, but what's the reality, at least in the US? What do we see on the right side? Obese patient, right? They have like 2-3 folds, and you can barely see the common femoral. And that's what we have to face with this. And I do have problems when I face this challenging, or as I call it, hostile groins with suture devices, because per close is just not. It's not just deploying it. First, you have to create a track, go in, see that you're at the level where you access, et cetera, and it could be very challenging to do that. So I think, and before we start talking about any closure technique, I want to highlight the rules of common femoral, and I call them my rules because I'm citing this article in JACC, How to Do a Femoral Access. And to be honest, I kind of so it's a good article. I think they don't mention some key points that I think are critical for any common femoral access. First, I usually fluoro first and locate the common femoral. Why? Because you want to be at a compressible site. Then I locate with the ultrasound the bifurcation and how is the plaque distributed. The calcium is anterior, posterior, lateral, is it soft, et cetera, et cetera. And then I think what is key, when everyone tells you should be above the bifurcation, to me, you should be at least a centimeter. Why? In case you need to bail out from ballooning or cover a stent, you don't want to be at the bifurcation. Why? Because if you have a mismatch from the profunda and the SFA into the common femoral, you can actually cause a rupture. Or if you have to put a cover stent, you can actually isolate the profunda and then have ischemia of your tie. So it's very important to have at least a centimeter. And also, remember, you have sometimes you have not one profunda, you have accessories, and those vessels are accessories. Don't like, if you have to put a cover stent or occlude them for 10 minutes, don't worry about them. They really don't have a real job there in the perfusion of the leg. So don't feel scared. And the other thing that is very important too, as they put in this JACC article, if you look at here, they did a high bifurcation and they took it. To me, if you have a really high bifurcation, but you have a good SFA size and it's like a functional common femoral, just take the SFA or look for the other leg or an alternative axis, or be prepared to deal with it. But don't take a high bifurcation just because you are above the bifurcation. You could do better than that. And the other thing that is very important, and I tell my fellows, there's no shortcuts. Go with a micropuncture. If you have severe calcified vessel, use the dilator of the micropuncture. Then if you're still having problems delivering the sheath, use the dilator of the 6 French sheath. It's a very good dilator, has much better tapering, smooth transition, so you can access the vessel. Then put a stiff wire. Then use your 8 French dilator. The MANTA, I think the measurement is 8 French, so you can facilitate the measurements with that dilator, and then go to the stiff wire. So I created this algorithm based on my experience, but I think this is how I approach patients. If you have an obese patient with hostile groin, I go with MANTA. Delivering the pericles down those folds sometimes is impossible, and you know you're going to need to bail out. So any obese patient, to me, actually, I go MANTA first. If you don't have an obese patient and it's a friendly anatomy, it's based on operator comfort. If you have circumferential calcium, in my opinion, I just go with MANTA. Those pericles will not go through, and if they go, they will not oppose the vessel wall. So MANTA, I think, works pretty well. Anterior calcium, again, I go with MANTA. And when you have posterior calcium, I've done it. It wasn't my first MANTA, but I would do it with careful, and the same with suture devices because they still can get stuck. So which MANTA do you use? For all my Sapien, at least in the US, we have Sapien and Medtronic. I use all 18 French MANTA. And for Medtronic, what I've been doing is I just go with the sheath, and then I try to avoid going sheathless with the valve. I think you do tear the artery when you do big bore exchanges. So I just go with the 18 French, put the valve inside, and then avoid exchanges. And I usually use a 18 French. You can use a 14. But you might have some oozing if you really had a difficult groin and you push and pull. And then I'm gonna mention some steps. Okay, first, you have to be proficient with the access. That's key. Second, use DSA. I don't use cardiac mode because there are several small branches. So you do an access, you don't know the branches, then you close, and you don't know where the bleeding is coming. So I usually use DSA. You use less dye. You can see all the small branches that can mislead you when you close. Second, if you get an access and you don't like it with a 4 French with a micropuncture, don't take it. It's easy to do manual. It's an elective case. You don't have to take it because you have it. And then if you take an access that was not properly done, then you have to deal with an 18 French sheet. That is a major problem. Second, after I always use a dilator to facilitate the MANTA measurements to skip skin like foreshortening or skin movements, and always deliver under fluoro. MANTA is a big bore device itself. I never send the MANTA without looking at the groin to see wire buckling, any resistance. You always have to do that. Never push the MANTA blind, or never push any big bore blind. You always look on fluoro. And then the good thing about MANTA also allows you to keep the minimalist approach for TAVR. I do all my TAVR with biradial, and I use MANTA, I would say 99% of the time, and it works great. It works great. Always, and remember, always is good. If you're dealing with a big bore sheath, always it's easy to go to sleep if you use one groin and not the second groin for the secondary access. That's why I still emphasize the importance of the minimalistic approach. This is important. Don't close any big bore without having the bailout equipment in the room. If you start closing and you don't have it, and then the patient is bleeding, that's a nightmare. Be prepared. Okay. I always have the a long multi-purpose from the arm, part in the iliac to inject. You're going from the groin, have any IM catheter and a UF ready to inject. Have 014 wires. If you have a hostile groin or very tortuous, you can have a wire part, even a balloon to inject to be ready. The other important thing, if you know the vessel side, don't go 1-to-1. If you have an 8mm vessel, don't use an 8mm balloon. You want a tamponade. You don't want to do a angioplasty. So I think tamponade, you have to oversize the vessel and go at low atmospheres. Second, always reverse protamine. Keep the blood pressure below 150. That's key. If you're closing any groin and the blood pressure is 200, the likelihood of bleeding is higher. If you can reverse protamine, I would be ready with a balloon, because meaning you're not going to be able to reverse the heparin until like in 30 minutes when it wash out. So it's always good to have a balloon if you're not confident with your access or you have a hostile groin. Okay. The other thing that I do, I use the Edwards balloon when I exchange the Edwards sheath for the MANTA, because you might have some edges and you don't want to also damage. So it's very unlikely the vessel, but it doesn't cost. You have the dilator there, so I use it all the time to remove the Edwards sheath. So a step for closure, I know it's a long list, but I think the key point is being prepared. Do everything on fluoro. Have a stiff wire and a J wire. Usually what I do, I deliver the MANTA over a stiff wire under fluoro. Then I take out the stiff wire and put the regular J. Have some by force to clean the groin. Check the measurements and slowly retrieve as a tilting, pulling maneuver the MANTA to avoid getting stuck or having big jumps when I'm doing it. And then once I reach the measurement, I do the same maneuvers. And there's something very important. You will see blood coming, and that's normal. You're in the vessel. Don't freak out and go fast. Otherwise, that's when you get the complications of bleeding after the MANTA. Just keep calm, keep the same pace of deployment, and you will be fine. And worst case scenario, if you have a balloon ready, or if you have already a catheter in the iliacs, you can send a balloon and do balloon tamponade. You can always go back to the 70s, 80s, and 90s where you can do manual pressure. I mean, manual pressure is still effective, though it's time consuming. Okay. If you see dissections, don't worry about it. If they're not flow limiting, patient is going to do fine. It's an outpatient follow-up. If it's flow limiting, you can always balloon it, as they show in the prior case. This is another example of how we do the TAVRs. You see a very friendly anatomy. There's some calcium posteriorly, but I think it's okay. You can see the accessory vessels here, the epigastric, the details of the femorals, always on the micropuncture. I see how the wire reacts. I take a baseline picture. It looks pretty healthy for a MANTA, no concerns. Then under fluoro, I send the MANTA. I know that the wire is not buckling. I know that the MANTA is going in the right direction, so I didn't cause any harm when I push it in. And then after deployment with DSA, I can see all the vessels that I knew before they were there without problem from the wrist, and patient can ambulate early. This is an early, I can't give much details, but we're going to present at ACC, a combined exposure to TAVRs and mechanical support in a year. And our one MANTA was deployed in 99.4% of the cases. The immediate hemostasis was in the 92% of the cases without doing anything else. And the rest of the ones where we didn't achieve that, we just had to balloon. And there was one case of cover stent that was very early in the phase of MANTA, where we didn't know it very well, and no other issues with the MANTA. And I can tell you, over the last year, I don't recall last time I had to balloon a MANTA for a TAVR. Like we know it so well that the patients really do well. There's no bleeding complication. And I think there's clearly that learning curve. Talking about learning curve, what's the learning curve? Some people take longer than others. If you do a lot of big bore TAVRs or mechanical support, I think it's going to be easier. For those that don't do it very often, it might be a little bit longer. You need to understand the device for that. You need to be very proactive. Remember, again, to reverse the ACT, blood pressure. Don't rush. Don't freak out if you see blood. We see blood all the time when we get access. Talk to your local representative. If you don't remember the steps, call them. They're always available. There's usually some oozing after you do the MANTA. Not usually, but you could see it. That's from the skin. MANTA is a vascular device, not a skin device. Okay. I would say the key number could be like 5 to do a good MANTA after you get your supervised. But some people might take longer, might need more than 5 cases. I don't think there's a magic word for anything in medicine. When we look at volumes, more than 50, more than 25, I think you need to have your ethics and know when you know how to do something and deal with it. And if you're prepared, if you're proactive, if you do have endovascular skills and knowing your limitations, I think you can get a fantastic results, as we say at Henry Ford, after we do our MANTAs, and you will do very well. And conclusions: know all the equipment, your materials, review your CT, know the vessel size, degree of calcium, and remember, MANTA is a big bore device. It's not a small angioseal, and you have to understand it if you're deploying it. That's it.
All right, Pedro, thank you very much for that. I don't know if I could say fantastic, man, but it was a great presentation. I really learned a lot. And I think one of the things that you really showed is that as TAVR becomes more and more a mature field, we really got to, address every single bit of it. It used to be that we were just trying to get people out of the room in one piece with the valve. Now we have to have optimized best results. How are you training your fellows up there? Are you training them both in Perclose and MANTA? Are you steering them one way or the other?
So, well, it's funny because from all the structuralists here, we have half and half, and some of them are sometimes Perclose, sometimes MANTA. So they get both training, but I do use Perclose for any other access. Actually, it's my first device for 8 French, whatever you want to use. So they get the training for Perclose. And there are some cases, for example, if the artery is too superficial, the plug is around 1 centimeter, like a cube. So you can do MANTA on very superficial arteries because you'll have the plug exposed. In those cases, I use a Perclose. So I do think any center where they have fellows, they will get very good exposure to Perclose, and it's not going to be a big deal. I do think you need to know both. We use also Perclose for big bore for veins when we do mitral clips or TMVRs, and it actually works pretty well. But that's how we train them. I'm sitting next to them. I show them the first, and then what I do, I'm standing on the head of the patient and tell them what to do. Like they're conscious. Don't go fast. That blood is okay. Don't freak out. Go slowly. Blah blah blah. And our fellows, I would say, they become more experts than we do after a couple of months because they do all the MANTAs.
Well, and it's also useful. Any large bore operator needs to have some facility in peripheral interventions. I don't do peripheral interventions as a standalone procedure very much myself, but I follow the policy. If I broke it, I'd like to fix it. Nicolas, how much peripheral experience do you think the interventional cardiologist needs to do to be a good large bore operator?
I think that's a good question. I don't believe that you need to be able to do below the knee interventions. I myself was trained in New York by Gary Rubin and his group at the time. And I did not do the specific peripheral training fellowship. So I did not do an additional 1-year fellowship in peripherals. But you do need some training, and you do need to get some exposure in large bore access before you do it on your own, I assume. And you do need to be able, to understand what your technology is to do a balloon angioplasty or a stenting in the peripherals, because it is something else than a coronary intervention.
Yeah. And I'm not formally trained and don't do below the knee interventions, but have had as much experience as I need to. I think the complication management for MANTA especially is up and over, or even from a radial brachial approach to manage it endovascularly. It does respond pretty well to balloon intervention, but unlike the perclos, when you can maintain wire position and simply upsize your sheath or attempt multiple angioseals and maybe control the vessel, you need to be able to go up and over. So that's a reasonable skill set. Pedro, what's your thoughts on that?
Right. I mean, for example, the case you show, I think actually MANTA, if it gives you some complication more than bleeding, it's like either a dissection. I always tell a fellow, I'd rather take a dissection than active bleeding because you can actually have more time to deal with it and think about it. So again, I train in New York at NYU, though we were neighbors there, but so we had a good peripheral exposure. But I do think you can get the training if you train in the structural and interventional. If you don't have the training, just be proactive. Go with your vascular surgeon colleagues or your interventional radiologist. And I do think if you're going to be doing big bore, I mean, it's okay to be dependent on the vascular surgeons. It's not a bad thing if you know your limitations, but if you really want to keep the TAVR, especially as it goes lower risk on a minimalistic approach, at least knowing how to bail it with a balloon up and over from the wrist is something that I think it's something mandatory. You can't just wait there. Let's say you have an obese patient that you can reach the groin. I think it's unacceptable to wait for someone else that know how to do it to reach to the groin. You need to have those skills.
Yeah, some facility with a crossover sheath, pinnacle flex, get a wire down. And we know a lot. We've got a CT, we know the size of the balloon, have 6, 7, 8 by 40 millimeter balloons in your lab. And the worst case scenario, just blow up a balloon and call for help.
Right.
All right. All right. I think we have a few minutes left to discuss it.
So Paul, one question for you and for you and Pedro. We have transitioned also to single access site. So we get access with a 5 or 6 French sheath in the superficial and then take the large bore in the common femoral artery. I think that is also that really streamlined it even further because now the patient only gets a single groin access. So we don't use the 2 groins or the 2 radials anymore. So we always have the right radial for our suture for our filters, because we still use filters in all our patients if possible. But then we have 1 sheath in the superficial femoral artery and 1 sheath in the common femoral, provided that the size of the superficial can accommodate a 6 French sheath, and we would prefer at least 4 millimeter diameter of the superficial femoral artery, and then it becomes even easier. If you end up with an occlusion, for instance, after a MANTA closure, then it's often just you just give some contrast injection to that distal sheath, and already the vessel opens up again. So I think that might even improve the speed and the safety of the procedure even further.
Yeah, that's a great point. And what you're talking about is the large bore sheath, and then below that on the same side, the 5 French sheath with pigtail. I know some U.S. sites have adopted that. We like that for when we only have single access. So we use that when the other groin is hostile or doesn't appear as inviting. But it is a technique, and your points are good. You don't need to do an up and over if you're already across, and that balloon to put the foot plate up becomes very simple. I'm not aware of any data, and again, I'm hesitant to ask you because you probably are aware of all the data.
Yes, there is a publication from the Cleveland Clinic last year in JACC Cardiovascular Intervention from Samir Kapadia's group, and basically they show good results. It's not better, but it becomes easier and faster.
Yeah, it's simply that worse. We have one of Samir's, Matt Summers is one of our attendings and one of our new partners, and he brought that with us, and he's a big proponent of it. So but I do think the overall, as we approach it, there's still an associated morbidity and mortality with groin complications.
Right.
These dedicated device like MANTA and iterations are specifically for this, I think, are really the future. And I think we got to keep working and try to get this complication rate as low as possible. So.
Can I just mention something like,
of course.
I agree that with you, it's a good option. I still believe 1 or 2 axis is better than 2. You still have to deal with a 6 French in the SFA, and if it doesn't seal, you can't compress. So to be honest, if you have what I do, I get the long multipurpose, the 125 centimeters. If you know that the multipurpose reaches at least the external iliac, your balloon will reach the armatas, even the 14. Most patients, the multipurpose reach even further low, and for example, I don't close if I don't have the multi in the iliac. So I know I can send a wire and send the balloon later. But if you really have a tough access where you have a never and you cannot go up and over, what I do, I keep the micropuncture wire just below in the SFA without putting a sheath, and I still have the balloon from the wrist. So if I have to bail out with a cover stent, I just get access through the multi through the wire, and I can deal with it. So I like to still keep the bi-radial. Actually, we're doing distal radial since the start of this year in all our TAVRs if we can, to preserve the radial for future interventions, and has been working pretty well.
That's great. I think the key, whether you do a contralateral, ipsilateral, or radial access, is you got to be good at it, and you have to have a backup plan, and you have to be able to escalate, and you have to be able to manage the complications, as an operator rather than calling for help. So I think that's a definite message that we're hearing across these sites. All right.